Hello, my name is Dr. Kiran S Shankar from the Department of Public Health and Dentistry, PMS College of Dental Science and Research. I'll be taking the topic finance in dental care. I'll be talking about the introduction, history, different mechanism of payment, and of course, conclusion. And health is always considered the fundamental human right. Healthcare services have been provided basically on fee for service. That is, the patient receives a specific service or pays the provider directly for service. This is a two-party system where the contract exists between the provider and the patient. In most of the developed and developing countries, traditional system of payment has been focused to third-party system, wherein an employer, union, insurance carrier, or an agency pays for health on behalf of the patients. In most countries, cost of healthcare services are rising sharply due to public's increasing demand for the health services, ever-growing technology of healthcare, lack of incentives in healthcare, higher quality of healthcare, and general inflation. As oral health is an integral part of the general body called as gateway of the body, the prohibitive cost of the dentistry deprives people from availing oral healthcare or dental services. In developing countries like India, very few people can afford to or utilize the oral health services regularly. Most of the people will visit dentists only for curative services occasionally, not for preventive services. As the cost of dental care continues to rise, the majority of the people cannot afford dental treatment, especially when it is being provided on a fee for service. Dentists are often puzzled when patients and public complain about the high cost of their dental care. In response to the barriers faced as a result of not being able to afford the cost of health care, various concepts and mechanisms of financing are born. Hence, it is not surprising to see a continuous stream of proposals and mechanisms being conceptualized to make healthcare amenable to the public. The history started with fee-for-service, the first mode of payment to the dentist with respect to the service received, main type of payment for many years, and even now we see fee-for-service as the most common type of payment. 1945, voluntary prepaid comprehensive dental care. In 1948, established in England of national insurance scheme, including comprehensive dental service. 1948, Basil B. Palmer of New York City founded Group Dental Health Insurance as open panel prepayment. 1949, Group Health Association Consumers Cooperative in Washington established a clinic dental service which changed from fee-for-service basis to prepayment. 1954, Washington State Dental Council organized Washington State Dental Service Corporation for helping administer prepayment dental care plan for children. 1966, Medicare brought medical care to the age of the U.S. without regard to the income. This did not include the dentistry but Medicaid debt. 1973, health maintenance organizations providing standardized comprehensive care to individuals in enrolled group. 1989, Delta Dental Plan and other agencies were covering about 107 million beneficiaries. As I said, but still fee-for-service continues to be the major mechanism of payment in many developing countries. The mechanisms of payment of dental care is an important essay question. Mechanism by which dental practitioners receive payment for their services can be grouped into private fee-for-service, post-payment plans, private third-party prepayment plans, salary, and public programs. Coming to private fee-for-service, it's a two-party arrangement and is a traditional form of reimbursement for dental services. It has been in existence since the evolution of dentistry and it still remains the main form of payment in many developing countries. Although alternate forms of payment for dental services are growing rapidly, at present private fee-for-service arrangement is still the method of payment in many developed countries. ADA defends fee-for-service as the most efficient way in providing dental care. When patient decides and visits the dentist, dentist suggests appropriate treatment or inform the patient for the fee-for-service. The patient follows the recommendation of the dentist and receives the service. The patient is then responsible for the fee. So advantage is that it is culturally acceptable and is accepted in many countries. It's the American way of doing business. It is flexible. Fees can be changed according to market conditions. Right now, for example, now the COVID situations, infection control is an expensive equipment, and also so fees has to be raised. So it's a flexible system. We can raise the fees. Dentists can also be able to practice price discrimination according to Robin Hood approach. What is Robin Hood approach? Basically, in which fees charged to wealthier patient can subsidize treatment provided to the poorer ones. And Is it ethical or not is a question. Administrative simple. Dentists rarely keep a written list of fees for procedures. It is only system under which some sort of dental care likely will ever be provided. Disadvantages are despite of flexibility and price discrimination, many potential patients who cannot afford for dental services. Those persons would thus be unable to receive dental care if private fee for service were the only financing mechanism of dental care. Thus, other forms of payment like budget payment, dental insurance came into existence in order to ease the financial burden on the patient in many developed countries. Post-payment or budget payment plans. It was first introduced in the late 1930s by the local dental practitioner in Pennsylvania and Michigan, USA. It is also known as budget payment plans. Mechanism for individual purchase of services. Dentists are frequently arranged to allow payment for dental care to be made at intervals for a period of time. Patients borrow money from bank or finance company to pay the dentist fee at time that the agreement to receive care is made. After the application is approved by the leading institution, the dentist is paid the entire fee. Patient then repays the loan with specified interest amount to the bank in budgeted amounts. This post-payment budget plan was developed with the idea of providing dental care to large segment of population, but was not done so. Studies of this plan show that it was primarily utilized by people of middle income rather than low income, and it was used primarily to finance prosthetic treatment. Although some strong post-payment plans is a successful mechanism, there were still problems associated with defaulted loans and low-income patients. It also have more difficulty being accepted as credit-worthy by the lending institutions. More, most recent method of credit payment of services have tended to bypass post-payment plans. By the late 1970s, many dentists were accepting credit cards in developed countries. Many patients now use the mechanism for purchasing their dental care in much the same way as they use them for purchasing goods and other services. Because of the widespread use of credit card, it is unlikely that post-payment plans will develop any further. So coming to the basic principles, bank should adhere to bring a workable relationship between the dentist, patient and bank. No charge by the dentist for broken appointments. Instances of uncompleted work, dentist must refund the entire amount due to uncompleted services. Minimum entrance fee. Members dropped out from dental society for non-payment of dues dropped out from the treatment plan. Members going into military services should maintain their status. No entrance fee for returning. Uncompleted work of deceased dentist should be paid for by his estate. So the essential features include for the plan to be successful, simple and yet a proper presentation of plan by the dentist to the patient. Notes should be explained to the patient. Credit information should be obtained. Total amount of the note should be stated. Amount of interest to be charged should be discussed. Length of time in processing the notes is important. Operating give acceptance or rejection within 2 days. Problems in financing include no one is in a position to state definitely value of services performed, and the cost may vary 2 times to 10 times for the same treatment depending upon the skill, experience, and reputation of the dentist. Bank can establish value for automobiles, appliances, or units of furniture, but it is impossible to determine the definite value of services provided. Third party or prepayment plans. Payment for dental services by some agency rather than directly by the beneficiary of those services. Payment for dental services are paid directly to the dentist by an agency rather than by the and the third party defined as the party to a dental treatment contract that may collect premiums, assume financial risk, pay claims, and provide cost of administrative services. So these are the routing of funds for the dental care here by the third party, the dentist, and the patient public. The language of contract. It is also the third party is also known as carrier, insurer, or underwriter, as you mostly know. The purchaser of the plan can be organized private groups such as a union or an employer, a union employer welfare fund, or a government agency. Usually, the third party refers to an insurance company, as I said, as a private carrier, and if it is a government, it can be a public financing. Now, come to private third-party payment in the dentistry, periodic premiums are collected to meet the cost of providing care as well as administrative cost of the third party. It has been argued that this arrangement should most most properly be called prepayment rather than insurance because it does not fulfill the classic definition of insurance. Earlier, dental care was considered insurable by the carriers based on the assumption that nature of dental need violated basic principles of insurance. Because to be insurable, a risk must be precise, definable, be of sufficient magnitude that if it occurs, it constitutes a major loss, be infrequent, be of an unwanted nature, such as a destruction of a home through fire, etc., be beyond the control of an individual, does not constitute a moral hazard, means that the presence of insurance itself should not lead to additional claims. All health insurance violates these principles as the illness is not predictable for the individual and healthcare is usually a wanted service. To get around these problems, insurance carriers came up with different types of payment like deductible, co-insurance range of healthcare services, health insurance only to group, and using pre-authorization and annual expenditure limits. Deductible co-insurance are important short notes that can be asked. Deductible, it is a stipulated flat sum that patient must pay towards the cost of treatment before the benefits of the program go into effect. It is sometimes called front-end payment. Currently, an example for this type is automobile insurance. Co-insurance or co-payment, it means that both carrier and beneficiary are liable for a share of the cost of dental services provided. For example, if a patient is to pay 20% of the daily cost of the hospital care, the absolute amount will vary depending on the actual hospital charges, a type of room. But in any case, it will be 20% of those charges, remaining 80% will be from carrier. Range of healthcare services. Some services are available and some are not as per plan. This range is termed coverage, covered charges, or schedule of benefits. For example, services such as dental implants, cosmetic restoration, and extensive temporal joint disorders are rarely covered. Pre-authorization, cost control mechanism widely used by insurers, also known as predetermination or prior authorization, means that treatment plans for more than a specified sum must be reviewed by the carrier's dental consultants to ensure that proposed reasonable and the same quality of care could not be achieved at a less expense. When the cost of treatment are expected to exceed some limit, the dentists are required to submit the treatment plan to ensure for review before the treatment begins. Group insurance, health insurance must offer only to groups because illness experience is reasonably predicted for a group, though not for an individual. Insurance covering group of persons, usually employees of a single employer or a member of a union, under one contract for benefit of the members of the group. Reimbursement of the prepayment plans. Major three parts of types of reimbursement, that is UCR, usual, customary, and reasonable fee. An important short note it is table of allowance, fee schedules, capitation, and direct reimbursement. What is usual, customary, and reasonable fee, or UCR? ADA preferred method for reimbursement for dentists in payment requirements is defined as usual, which is the fee that an individual dentist most frequently charges for a given dental service, and fee customary, that is a fee level determined by the administrator for a dental benefit plan from actual submitted fees for a specific dental procedure to establish maximum benefit payable under given plan for the procedure. A reasonable fee charged by a dentist for a specific dental procedure that has been modified by the nature and severity of conditions being treated by unusual circumstances. Whereas in conditions like, sometimes in a root canal treatment, there is sufficient dilaceration that when the root canal procedure is more difficult, we can charge a little more because of the severity of the condition. That is reasonable. Table of allowances, defined as a list of covered services and assigned amount to each service. So coming to fee schedules, also called as service plan, is defined as a list of charges established or agreed by a dentist for a specified dental services. Capitation is a dental benefit program in which a dentist or a dentist contracts with a program sponsor or administrator to provide all or most of the services covered under a program. In direct reimbursement, the program involves an agreement between the employer and employees in which employer agreed to reimburse the employee for some parts of the expense. Commercial insurance companies basically, the name suggests, commercial, and this company operate for profit. Cash payment for providers. Companies pay the dentist directly for the covered services, and payment is quicker. The carrier develops fee profile based on prevailing fee in a given area, and dentists are paid at that rate. There is no periodic post-treatment evaluations to assess the quality of dental care delivered. About 90th percentile is what a short note that can give us. You have to take down the diagram. About Delta Dental Plan and Blue Cross Shield. Delta Dental Plan was born for the purpose of providing comprehensive dental care for children up to 14 years, and corporation was legally constituted not for profit organizations but is operated on state-by-state basis that negotiates administrative contracts for dental care. The characteristics of Dental Service Corporation are professional sponsorship, non-profit operation, and participation based by all licensed dentists. It was supported and funded by ADA in April 1969. Delta plans covers up to 20 million people in the US, account for 25% of the total claims paid annually. Reimbursement of dental plan used an UCR concept clearly and depends on participating and non-participating dentists. Participating dentists plan as fully dentist, licensed dentists with whom a Delta plan has contractual agreement to render care to cover services. Does include pre-filing of their usual customary fee, acceptance of payment for the service at 98th percentile, fee audits by auditors from Delta who may check their office, post-treatment inspection of randomly chosen patients to monitor quality of care, withholding of small amount of each fee, usually less than 5%, go into Delta Capital Reserve Fund. And non-participating dentists can also treat patients in Delta plan and get reimbursed by dental plan. They do not need to follow any conditions, but they are paid at 50th percentile rather than 80th or 90th percentile. These are my references. Thanks. Have a good